In a case of dysphagia or difficulty swallowing, using our mnemonic old cards as our guide, we note the onset, or when did it begin. For location, is this more of an oropharyngeal or esophageal dysphagia? As we see below, an oropharyngeal dysphagia is a difficulty initiating a swallow, such as a choking, coughing, gagging, drooling, or an aspiration. An esophageal dysphagia is more of a sensation of food sticking in the chest. For duration, is this constant, occurring at all meals, or more intermittent, as we'll see in diffuse esophageal spasm? If it is intermittent, we'd like to note the frequency. How often is this occurring per day? And we can note the progression. Does it seem to be occurring more frequently? To help us characterize, we'd like to note if this is occurring with solids, liquids, or both. We can ask now or later in our review of systems of any GERD or dyspepsia symptomatology, such as heartburn or an epigastric pain, early satiety or fullness, or nausea, aggravating and alleviating factors, and treatments tried. In the course of our history, our patient may be concerned and ask us what happens if they choke the next time. We can help reassure them and ask them if they can tolerate softer foods in the interim. For all cases of dysphagia, we'll order a CBC, serum electrolytes, and chest x-ray. In a Zenker's diverticulum, we'll see oropharyngeal dysphagia, halitosis or bad breath, regurgitation, and it will be aggravated by large food or alleviated by small food. We'll add to the workup a modified barium swallow, which helps us visualize the pharynx and the larynx. It involves consumption of foods and liquids of different thickness, each with small amounts of barium contrast material, and also a laryngoscopy. In pharyngeal cancer, we'll see oropharyngeal dysphagia progressing from solids to liquids, aggravated by large food and alleviated by small food, and the characteristic weight loss or decrease in appetite for cancer, and our patient will be a history of a smoker or an alcoholic. We'll also include the modified barium swallow in the laryngoscopy. In neurogenic dysphagia, our patient will have oropharyngeal dysphagia. It will be aggravated by large food and alleviated by small food, and our patient will have a history of a recent stroke, Parkinson's, or ALS diagnosis. We'll also include the modified barium swallow and laryngoscopy. We'll further break down our esophageal dysphagia into mechanical and neuromuscular etiologies. Mechanical, progressing from solids to liquids, and a neuromuscular or motility disorder having concurrent solid and liquid dysphagia. We'll let the E in the esophagus help us for the three different esophageal pathologies. In esophagitis, we'll see esophageal dysphagia progressing from solids to liquids, aggravated by large food and alleviated by small food, and a pain on swallowing. Our patient could also have a history of GERD, HIV, or certain medications. We'll order the barium swallow, which is a contrast esophagram, helping us visualize esophageal anatomy, and an endoscopy. In an esophageal stricture, we'll see esophageal dysphagia progressing from solids to liquids, aggravated by large food and alleviated by small food. Our patient could also have a history of GERD and certain medications. We'll also add the barium swallow and endoscopy. In esophageal cancer, we'll see esophageal dysphagia progressing from solids to liquids, aggravated by large food and alleviated by small foods, and the characteristic weight loss or a decrease in appetite for a cancer. Our patient can also have a history of being a smoker or an alcoholic, and we include the barium swallow and endoscopy. In Plummer-Vinson syndrome, we'll see the esophageal dysphagia. It will be progressing from solids to liquids, aggravated by large food and alleviated by small food, and our patient will have a characteristic fatigue due to the iron deficiency anemia and certain food cravings, such as ice. We'll also include the barium swallow and endoscopy. In achalasia, we'll see esophageal dysphagia. It will be constant, occurring with both solids and liquids, aggravated by large food, alleviated by small foods. Our patient can have a history of a recent travel to South America. We'll include the barium swallow, endoscopy, and add an esophageal manometry. In scleroderma, we'll see the esophageal dysphagia. It will be constant as well, occurring with solids and liquids, aggravated by large food and alleviated by small food. Our patient can have a history of GERD. We'll include the barium swallow, endoscopy, and add an esophageal manometry. And finally, in diffuse esophageal spasm, we'll see an esophageal dysphagia that's now intermittent. It will be occurring with both solids and liquids, aggravated by large food, alleviated by small food, and a characteristic chest pain. Will include the barium swallow, endoscopy, and an esophageal manometry. Okay, we'll start our abdominal exam with a hand sanitizer, and we want to ask our SP if we have permission to examine you. Okay, and we'll start with the hint exam. We'll look into his eyes if we're going to be concerned about jaundice in an abdominal case, so we'll make a comment that there's no scleral icterus, and look down, please. Okay, we'll move on to the oral pharynx, so we'll use a tongue depressor here. The key thing to do is you don't want to add too much pressure for the SP, so just very lightly you can press down and ask them to please stick out your tongue. Okay, and we'll comment that we don't see any lesions. We'll examine his thyroid, and so another good tip is to offer a glass of water. Would you like a glass of water? No. Okay, and now we could look to see if there's any visible lesions to the thyroid, and we don't see that, so we could ask him to swallow, and we could do one side at a time. Okay, now please swallow again. Okay, we didn't feel any palpable thyroid nodules. While he's still sitting up to the cardio exam to get that out of the way. So the best way to do this here is, again, to lower the gown slightly, to ask them to please sit and hold it like this. This will protect them and keep them covered up. We want to verbalize that we don't see any visible lesions in the anterior chest, no visible lesions to the posterior chest. We'll go ahead and palpate and see if he has any chest tenderness. So please let me any pain. Okay, we'll do the same thing on the back. Next thing we can do is auscultate for his heart sound, and so we'll use the mnemonic apartment M225A, and we'll listen first in his right intercostal for the aortic, and we'll go over to the left for the pulmonic, and then we'll go to listen to the tricuspid. And now for mitral, if this was a female, a good tip is to ask them to please lift up your upper breast. We could comment that we hear an audible S1, S2, regular rate and rhythm, no audible S3s, S4s, or murmurs, rubs, and gallops. Once we completed the cardio, we could transition nicely to the pulm exam while he's still sitting up, and so we could go ahead and percuss. We'll start above his clavicle, comparing left to right. And I'm going to go ahead and do the same thing on the back, 3 spots. We could auscultate again. We'll start above the clavicle. We're going to use the bell first. Please take it in the instructions you want to give. So please take a deep breath when you feel my stethoscope. Please take a deep breath in and out. Okay, compare left to right. Do the same thing on the back now. Okay, now we could verbalize again that it was cleared auscultation, no audible wheezing. Once we concluded the cardio and pulm exam, we could cover him up again. Now we can instruct him. I'm going to now lie you down to do the abdominal exam. Is that all right? Okay, so we want to help them down. And you don't want to forget to extend the legs for the leg rest. Now you could rest your legs. For the abdominal exam, they'll have a gown here, and you want to move it up all the way to their pelvis, and then you want to ask permission to take it up. We want to do the same step again. We want to first verbalize that we see no visible lesions, and after we completed that, we're going to now listen. We're going to auscultate. First, ask if he has any pain anywhere. Yeah. Okay. Now we could verbalize that we heard normal active bowel sounds, and then we'll go ahead and percuss in the 4 quadrants. Okay, and we want to ask them if they have any pain first. You want to avoid those areas. So do you have any pain anywhere? No. Okay, so we'll start in the lower quadrant here, and we'll do superficial first, just with one hand. We could make good eye contact with the SP to see if they have any pain or if they wince. Painful at all? Okay, now we'll go ahead and do deep, and for that we could just signal we're going to put one hand on top of the other. Any pain at all? Okay, so no pain. And then to conclude,
want to check hepatomegaly or splenomegaly, so we want to place our hand under his liver. You can instruct them to please take a deep breath in. And now as he breathes out, you don't want to feel anything, any liver border below the rib cage. So once you feel the rib cage and nothing extending further, you can make the comment that there's no hepatomegaly, and you could do the same thing on the swing side. So you could please take a deep breath in. Okay, and now breathe out. And then you can feel the lower border of the left rib cage and no organ extending below it. Okay, so now you can cover them up again. And then you want to help them sit up. And then just ask them if they have any questions. And then that would conclude the exam.